Assalamu alaikum. So today, inshallah, we'll be talking about aortic coarctation, which is a nice topic. So we'll be talking about general anatomy of the arch, types of coarctation, presentation, management, different techniques. There are lots of procedures, either surgery or by cath, and complications of each, and then a general overview of how to manage the patient and what procedure to choose. So generally, aortic arch starts from the ascending aorta when the first arch branch comes off. So we've got innominate artery, big cephalic artery, giving subclavian carotid. Generally, in most patients, this is the left-sided, so these are right subclavian, right carotid, and then left carotid, left subclavian, and then the either patent ductus arteriosus or ligamentum arteriosum is attached somewhere like here, okay, and then you get the descending aorta. So the arch is from the start of the branching, so from the site of the innominate artery till the site of the attachment of the ligamentum arteriosum, not just the subclavian. And then we can subdivide the arch into different segments. So proximal arch is from the brachiocephalic to the carotid. Then distal arch is from carotid to subclavian. And then there is the isthmus, which is again more distal to the distal arch. So the distal arch is not the end of the arch. So the isthmus is from the site of the subclavian, left subclavian, till the site of the attachment of the ligamentum arteriosum. So proximal arch, distal arch, and isthmus. This has embryologic origin because each part has a different embryologic origin, but then we'll try not to go into embryology here. There's a different separate talk for that. So what is aortic coarctation? Aortic coarctation is some sort of narrowing at any of these. Usually you get narrowing at the isthmus, plus or minus some narrowing into other segments of the arch as you go more proximal. This is not a rare disease, so it accounts like 5% of patients with congenital heart disease. Sometimes it comes as an isolated lesion, but actually quite frequently comes as in association to other diseases. However, patients with Turner syndrome have really high incidence. Up to one third of patients with Turner syndrome might have aortic coarctation. And the overall incidence accounts for like 0.2 to 0.6%, 0.2 to 0.6 per 1,000 live births. So how does a patient develop aortic coarctation? There are different theories for that. The most common and well-accepted theories are flow theory. And flow theory says that during fetal life, if the blood flow into the arch, essentially to the end of the arch, is less than normal, then this part will not fully develop, and then it gets narrower, and then you develop coarctation. And so the intrauterine or the fetal lesions that cause blood to be less at that part of the arch will be associated with coarctation. So again, we'll not go into depth of fetal circulation, but then you know that blood going into the arch is coming from ascending aorta, while most of the blood going to the descending aorta is coming from the pulmonary artery through the ductus arteriosus. And so in the lesions that cause blood to shift before going into the ascending aorta, then this will get less blood into the distal part of the arch, and then you get coarctation. So something like if a patient has a VSD, then less blood will go into the ascending aorta. If they have bicuspid aortic valve, aortic stenosis, mitral stenosis, so anything causing less blood to go into the ascending aorta. Schon syndrome, where you get narrowing on the left side, your mitral stenosis, LV obstruction, aortic stenosis, aortic coarctation. So one of these theories are that there's inadequate flow into the fossa ovalis, so the amount of blood going into the left side of the heart during the fetal life is less than normal. Then, so these lesions have actually quite high incidence of association with aortic coarctation. On the other hand, it's quite rare to get patients with RVT obstruction, like patients with Fallot, to get aortic coarctation. It is still reported. We have seen patients with Fallot and coarctation, but it's really, really rare. And that's why flow theory is quite considerable. But then there are other patients who have coarctation and do not have these lesions. So there should be probably another theory, so which is the ductal sling theory. So, this is the ductus arteriosus, so ascending aorta, arch descending, and these are MPA, PA branches, and then that is the patent ductus arteriosus. And then after birth, the duct closes by constriction of the smooth muscle in that wall. And then at first it closes functionally, and then this becomes a structural ligament. In some patients, the ductal tissue might actually creep into the aortic arch, the distal part of the aortic arch at the isthmus, and then causes like a sling around that part of the arch. And then when the duct tries to close, the ductal tissue contracts, this also contracts over the isthmus. And then you get narrowing at that part of the aorta, which is the ductal sling theory. And that is supported by when patients do surgery and this part is excised, you can actually get histologic tissue of the duct into that part of the aorta. So this is also an important part. So patients who develop aortic coarctation fall into a wide spectrum. So there can be very localized coarctation at the site of the isthmus. But on the other hand, you can get coarctation at the isthmus, but also all the way along the distal and proximal arch. You get also a hypoplastic arch, and the amount of blood flow going from the ascending into the descending is actually very little, so that most of the blood going into the descending aorta is dependent on the presence of a patent ductus arteriosus coming from the pulmonary artery. And some of these patients actually have duct-dependent systemic circulation. So they depend on blood coming from the PDA into the descending. On the other hand, other patients have very localized coarctation. So they call that infantile coarctation, or like preductal coarctation, as opposed to patients with localized coarctation called as postductal or adult type coarctation. So this is the patient that has a long narrow isthmus with a small arch, having the part of the spectrum towards the infantile coarctation, or the preductal one. This is the PDA, that is the descending. On the other hand, this is a well-developed arch with localized coarctation, again with a PDA going into the descending. So patients can have a really small aortic arch. So to get you oriented, this is ascending aorta, arch branches, big phallic and carotid, then very small aortic arch. This is subclavian, and that is the descending aorta. It is big size because it has been developed by the blood passing through a big PDA, patent ductus arteriosus. This is the pulmonary artery. Okay. So this is a patient with a hypoplastic aortic arch, and the descending is essentially supplied by the patent ductus. So how would you define hypoplastic aortic arch? So how small is small to say that this aortic arch is small, not just the isthmus? So there are different definitions for that, for different patients. So one easy definition is that if the part of the arch is has a z-score of less than -2. So you have z-scores, and then if part of the arch is less than minus 2, then this is the hypoplastic part. And now we're talking about arch proximal to the subclavian artery, because distal to that is isthmus. Okay. One other definition is saying that if that part of the arch has a diameter that is less than the diameter of the ascending aorta. So normally the ascending aorta is bigger than the arch because blood goes into the big cephalic and then becomes smaller. But if it is less than half of the ascending aorta, then this arch is not big enough. This is hypoplastic arch. A third one, which is an easy one to adjust, especially for small babies. So aortic arch that has a diameter less than body weight plus 1. So if a newborn baby is 3 kilos, then if the arch is less than 4 millimeters, then this is hypoplastic arch. Okay. So if you look at that specimen, it is actually quite easy to misinterpret this large duct as the aortic arch. And this actually can be seen like that in echo. So you can very easily miss a patient who has a hypoplastic aortic arch by seeing a large PDA continuing into the descending aorta. And then you just say that the arch is adequate. Well, it is not. The arch is actually quite tiny. So to be able to define aortic arch in echo, it has to give head vessels. While here you just see the subclavian, but the brachiocephalic and carotid are quite far away. So just make sure you do not miss this on echo. While on the other hand, this is a discrete coarctation, so a localized coarctation with adequate arch and isthmus. And then that's the descending aorta. Sometimes we actually look on the aorta from outside, essentially during surgery, and then you think, okay, the isthmus is small, but it's not that narrow, not that tight. Well, actually, you underestimate how narrow is the actual orifice, because you frequently get a coarctation shelf. So although the outside of the aorta, so this is the part of the isthmus that was resected during surgery, and then you can see that although the aorta from outside is not too bad, but actually the actual orifice is very small. Sometimes it can be really, really tight. So how do these patients present? So one end of the spectrum is getting patients with really low flow into the descending aorta, and then once the patent ductus arteriosus closes after birth, then patients goes into acidosis and circulatory collapse, where essentially not enough blood going into the lower half of the body, and then they present with circulatory collapse, acidosis, severe heart failure, anuria, and so on. How would you manage such a case? Take him quickly to surgery. Prostaglandins. So the major change that has happened after birth is that the ductal tissue has closed. So that closed the ductus arteriosus itself, but also with the ductal sling theory, this has actually closed the aorta itself. And so if you give prostaglandins, then the ductus arteriosus open, so the descending aorta will be supplied by blood coming from the PA, which is okay. And also the tight coarctation actually gets less tight because the ductal tissue in the aorta will get loose. One other presentation is presenting with heart failure. So patients, they still have enough blood going into the lower body to have these perfused. But on the other hand, the ascending aorta has really high pressure because of the very high afterload. So the heart is facing very high afterload, and then it fails. It doesn't even have the time to get hypertrophied, and then, so some of these patients present with heart failure because and very early on in life, first few months, because of the very high afterload. So there's a patient who is 2-3 months old, and then he presents with tachypnea, failure to thrive, and then he has an echo that shows severely impaired left ventricle. And then looking at the arch, there was no gradient because the coarctation was very, very tight that you can hardly see any flow there. And then, so there's no turbulence, no gradient, nobody diagnosed coarctation. And then you just label that as a dilated cardiomyopathy. And then you miss the whole point, because patients with dilated cardiomyopathy at 2 months of age do not have a very good corrective treatment, while on the other hand, patients with tight coarctation have essentially a curative intervention. And so, please do not diagnose dilated cardiomyopathy in a small child before you exclude coarctation and other causes that cause something like that, like the L-kappa and atrial tachycardia. These things have treatments, and then you can miss a big thing. So the coarctation and the L-kappa can be quite difficult to be diagnosed by echo and are very well delineated in CT. So please do not label patients as dilated cardiomyopathy before excluding such things. So circulatory collapse, heart failure. Others might actually grow older as older children or even adults, and then they just present with hypertension. And then the hypertension is resistant to the usual treatment, and then that's one of the causes of the secondary hypertension. Because if you have the afterload very, very high, then the pressure proximal to the coarctation segment is quite high. And then they present with headaches and complications of hypertension. Others, again, during adulthood, can present with claudication because of insufficient blood flow into the lower body. On the other hand, some patients might get enough collateral flow to be almost totally asymptomatic. And then they're just diagnosed by someone heard some murmur or on routine measurement of blood pressure, they found to be hypertensive. So patients can have enough collaterals above and below the coarctation. So this is tight coarctation. And on the other hand, all the intercostal arteries and the internal mammary arteries are very, very dilated. So there are collateral flow above and below the coarctation segment so that the descending aorta gets filled by this collateral flow. So should we do anything if the patient is asymptomatic and then there's enough blood flow going into the descending aorta? Yes, we should. Why? Because there are important sequelae for patients having significant coarctation. So we've discussed patients can get heart failure because of the high afterload. They develop much earlier coronary artery disease with these coronaries subjected to very high pressure for years. Patient can get aortic aneurysms, dissection, and rupture. Please note that there's a common association between bicuspid aortic valve and coarctation, and the bicuspid aortic valve actually has aortopathy, so the aortic wall is also abnormal. So these patients even develop have higher incidence of developed aneurysms and dissection. But on the other hand, you do not need to get aortopathy to have these things. So the high pressure in the ascending aorta. Some might actually first present with cerebral hemorrhage because of these very high pressure proximal. Patients with long-standing aortic coarctation develop irreversible changes to the systemic vascular bed. And these patients, even after treatment of the coarctation, they stay hypertensive. And so it is very important to get the treatment quite early to avoid developing irreversible changes. So how do you diagnose coarctation? Obviously with history, and these are the classic X-ray findings, which we do not rely a lot, but just for your interest. So this is rib notching. because of the very well developed collaterals, and then the intercostal arteries become bigger and they compress the undersurface of the ribs. And the figure of 3 sign, where you get dilated arch, then narrow isthmus, then a dilated descending aorta. Quite imaginative. On the other hand, we actually diagnose coarctation by echo. Not necessarily looking at the arch, but actually looking at the flow in the descending aorta. So normally flow in the descending aorta will be triphasic, so most of the blood going into the systole, and then during diastole, tiny flow backward, and then there's almost no flow during diastole, which is like this one. So during the diastole, there shouldn't be forward flow. On the other hand, if a patient has a fixed obstruction at the distal arch, then during systole, the blood was struggling to pass this obstruction. And then still during the diastole, blood will continue moving from the ascending to descending aorta because the pressure in the ascending is still higher than the descending. And so you get still forward flow into the descending aorta during diastole. You call that tailing, so that instead of having almost no flow during diastole, you continue having, so this is the big systolic wave, but all through the diastole, you continue having forward flow from ascending to descending. And this is detected by subcostal view into the descending aorta. You do not even look at the arch. You just detect the pattern of blood flow into the descending aorta. But on the other hand, from the suprasternal view, you can get a picture of the arch. So this is ascending aorta with arch branches, and then descending aorta, and you can see a part of narrowing here. And then if you put color Doppler, you see turbulence and a high gradient there. So this is an example of adequate sized aortic arch but narrow isthmus with localized coarctation, as compared to this where you get hypoplastic aortic arch. So CT and MRI have much higher, more important role than echo. You can detect a lot more details. So this is a CT image showing the localized coarctation. Here you can see very tight coarctation. So this is ascending arch. This is the origin of the subclavian, while very tight coarctation before giving the descending aorta. Here you can see a 3D reconstruction of a CT showing the ascending aorta, arch, very, very tight coarctation, nearly interruption before giving the descending aorta. And then you can see the very dilated branches. Have a look on the antenna mammary artery. These should be quite tiny. These are as big as the subclavian arteries. So these account like collateral flow from the upper part to the lower part of the body. Again, that's an image showing, so this is the descending aorta. This is main pulmonary artery giving left pulmonary artery. This is patent ductus arteriosus going from the pulmonary artery and then supplying the descending. Well, this tiny thing is actually the arch, and you can see the head vessels coming off there. So this is a patient with a really hypoplastic aortic arch. That's an image from the back showing the very small aortic arch with head vessels coming off. So cephalic, carotid subclavian, hypoplastic aortic arch, and the descending aorta is essentially supplied by the patent ductus arteriosus. So clinical examination history, essentially echo. There are some X-ray findings, but the hallmark here is either CT or MRI. So the value of the CT is it has much higher resolution, so you can detect very well the anatomy of the arch on the expense of giving dye and radiation. On the other hand, MRI can detect that with less resolution, but essentially in small babies will require a CT. So indications for interventions here are symptomatic infant. Obviously, if a patient presents with a circulatory collapse and requires ventilation and prostatin, or in severe heart failure with cardiomyopathy, essentially he is very well indicated. On the other hand, patients who have a gradient of more than 20 millimeter mercury across the arch is indicated for intervention. And any patient presenting with hypertension or LV hypertrophy. So when do we intervene? So in patients with any symptoms, they have intervention once diagnosed, and this includes patients who present in the first week of life. So this can be quite emergency, and then you need to deal with that. They may need some stabilization with prostatin. Most of the time they don't, but very well patients can present in a really bad general condition. So stabilization with prostaglandin can improve that. Patients who are actually in a really bad general condition, severe circulatory collapse, acidosis, might benefit from a quick balloon angioplasty, so that you stage that and then you do the definitive repair then. The problem with the balloon is that the recurrence rate is quite high. So just like a stabilizing measure before doing the definitive repair. On the other hand, patients who are asymptomatic, if they're diagnosed, they should have the intervention before the 2 years of age. Again, because of the irreversible change that will occur into the systemic vascular bed, and then you get the sequelae and the long-term sequelae of systemic hypertension. So do we do that by surgery or cath? There are different variables here. So patient age. So if you need, we've just said that if you do a balloon, the recurrence rate is very high. So again, this is not a permanent solution. So essentially, we're talking about surgery versus cath. Is that are we doing surgical correction, or are we putting a stent into that narrow part? So if a patient is very small, there's a limit to the size of the stent that you can put. Okay, some stents can be real dilated, but still, if a patient is 3 kilos, then he needs to have the arch at least 4 millimeters. And then if you put a 4 millimeter stent, this would not grow into adult size. So the size of the patient is important. So you're more likely to do surgery if the patient's small. While on the other hand, if the patient is an adult, and then you put an adult size stent, then you actually are okay with that. On the other hand, patients who have a recurrence after surgery are better suited with cath, because then resurgery is actually a lot more difficult than the previous one. And the major problem with cath is that you have higher likelihood of developing dissections, because if you put a stent in a very narrow aorta and then you try to dilate that, then you can get rupture or dissections. Patients who had previous surgery will have dense adhesions around them, so they are more protected. Obviously, it is not fully protected, but you're less likely to develop major problems with adhesions around it. And general condition, we've just mentioned that patients with very poor general condition might be palliated with a quick balloon before doing definitive surgery. And so a balloon or stent, if you do cath, essentially balloon is very temporizing measure that should be done in patients with really, really bad general condition. So it should not be done as routine, because it will occur. And we're not talking about a patient who has like 3 months of age and has high gradient. This can just go to surgery. On the other hand, if a patient is ventilated with acidosis, severe circulatory collapse, and very bad labs, then you can have a case for doing balloon. But on the other hand, if you do a stent, there's a good indication for that if the patient is approaching adulthood or has recurrence after surgery. And then you can choose putting a covered or non-covered stent. So covered stent is essentially a stent that has like a tube graft around it, so that while non-covered stent, you have open struts, so that sometimes if patients with very, very narrow coarctation, and they're in adulthood, and you want to enlarge that into adult size aorta, you're actually inducing a controlled rupture, because and then you're a lot safer putting a covered stent there. So you put a stent that is covered by a tube, by a synthetic graft, and then once you open that, aorta ruptured, but it is controlled inside the tube so that it doesn't leak, while if it is non-covered, that this might not be protective enough. So we'll go through some techniques. Essentially, this is one of the diseases that have many different techniques, which says that there's no one technique that is ideal. And that's why different scenarios might require different technique. So an easy to think about technique here is you just cut off. So this part of the isthmus was narrow, the localized coarctation. So you just cut off that narrow part, and then you connect them together. So this is cocktectomy with end-to-end anastomosis. Quite an easy procedure, does not take a lot of time, but then has a really high risk of recurrence. And the recurrence occurs because this suture line gets fibrosed and gets narrower. So you get a high risk of recurrence here. So this is a surgical view. So the baby is on his, so he's lying on his right side. We open on the left side, assuming it's a left arch. And then, so this is the site of the head of the baby, and here are the feet. We're looking from the left. So here is ascending arch. This is the coarctation segment and descending. Here are head vessels, cephalic carotid subclavian, coarctation segment. This would be the site of the PDA. So you just put 2 clamps on the arch and on the descending aorta, cut off the coarctation segment, and then you just connect them together. And you end up with this configuration. Again, relatively easy procedure with high recurrence rate. The other option is cutting across the coarctation segment, cutting across the narrowing, and then putting a patch there. So if you open across the isthmus, and then you find the coarctation shelf. Do you remember the picture where you can see shelf filling most of the lumen? So you just cut off this coarctation shelf and then put the patch. Okay, and you end up with pseudoaneurysm. When you cut off the coarctation shelf, you actually cut off intima and big part of the media. You're essentially going into the adventitia of the aorta. And then, so if you cut off this thing, that part of the aorta becomes non-supportive. And then with high pressure inside the aorta, you get really high risk of pseudoaneurysms and maybe later rupture. So, okay, we just cut across the coarctation segment. We do not take off the shelf, keep it, and then still put the patch. You still develop aneurysm. We're not sure why, but then they develop aneurysms just opposite to the patch. It might very well be because of the aortic wall is elastic, while this synthetic patch is not elastic. And then blood will just come and hit the part in front of the aorta till they develop aneurysms. So again, patch aortoplasty is an easy to do procedure, very effective in relieving obstruction, but on the other hand, it does not grow, and there's high incidence of aneurysms and pseudoaneurysms. So again, this is a surgeon view. This is arch descending, so you cut across the narrow isthmus into the descending aorta, and then this is the coarctation shelf. Should not cut that, and then put a patch across that, usually a synthetic patch. So this is something similar to the patch, while actually using a native tissue, arterial tissue. This is subclavian flap. Okay, so surgeons are used to just dividing the subclavian artery. Okay, the classic BT shunt was essentially dividing the subclavian artery and putting that on the pulmonary artery. So this is, you divide the subclavian artery, and then you cut across the subclavian artery into the isthmus, all the way into the descending, and then you just turn that over to augment the small part with native arterial tissue. So you use the subclavian artery wall as a patch, and then it wouldn't get aneurysm because it is elastic like that. And actually it grows. So there's a good advantage here. On the other hand, the subclavian now does not have supply from the aorta. Most of these patients have enough collaterals, so you very, very rarely get catastrophic gangrenes and ischemia. But on the other hand, it has been reported that the limb with the subclavian divided does not grow like the opposite limb. So there's a growth problem here. So that's subclavian flap. So this is arch, subclavian, isthmus, descending. So you divide the subclavian all the way up. You cut that all the way into the descending, and then you turn that over into the descending aorta, the subclavian flap aortoplasty. So there is a variation of that in patients with hypoplastic aortic arch, where the narrowing is actually proximal to the subclavian. So again, you cut the subclavian, and then the incision would go from the subclavian into the arch rather than from the subclavian into the descending. And then you turn that over into the arch to augment the aortic arch. You call that reverse subclavian flap. Another relatively simple procedure is just cutting out the coarctation segment and putting an interposition graft. You put a synthetic tube instead of the part that is narrow. So arch, subclavian, descending, this is the coarctation segment. You cut that off, and then you put a whole tube in between. So the obvious problem here is that tube will not grow. And so it is not an option in very small babies, because then this tube will not grow and actually cannot be dilated. So sometimes if you put a stent in a child, you can later redilate that, while if you put a synthetic tube, you cannot. But then it is an option in patients with who are adults and they are not suitable for cath stenting. Another technique is you just ignore all the way the arch, and then you do an extra anatomic bypass from the ascending to descending. So this is typically done via astronotomy. You usually go on bypass, and then you put a tube, connect that from the ascending aorta, and then you go all the way into the descending aorta. You get that access by going into the posterior pericardium, and then you find the descending aorta just there, either above the pulmonary artery or around the right atrium, either in front or behind the IVC. And then you go. The obvious problem here, again, this would not grow. So it is an option only in adults. But then why would you do that instead of just repairing the arch? Sometimes the anatomy of the arch is quite complex. So if the arch is very tortuous, or actually a patient who had a previous coarctation repair and then had a recurrence, and then put a stent and then had recurrence, then you do not want to go there. So this is another option. Going from ascending to descending, you just bypass the obstruction, and then you get enough blood into the descending aorta, and the afterload is this. So that's a post-operative image for patient with extra anatomical bypass. So do you remember this cocktectomy with a simple end-to-end anastomosis? So we said this is an easy procedure with a high recurrence rate because of this narrowing. So there's a variation of that where you not just cut across the coarctation segment, you actually extend that incision into the untoed surface of the arch and on the opposite side of the descending. And then you get a really wide opening, like that. And then you start getting this part of the descending all the way into there. And that part of the arch here, to end up with a configuration like this. So we call this cocktectomy with extended end-to-end anastomosis. And this is interestingly have lower recurrence rate than the simple end-to-end anastomosis for different reasons. Because you essentially start with a much wider anastomosis, so it's less likely to get narrow. On the other hand, if this suture line gets smaller, actually the arch gets shorter and not narrower. Because now the suture line is almost very near to the long axis of the arch. So you get much less recurrence with this. On the other hand, so at any part, the diameter of the aorta is either the arch or the descending. So here is arch, here is anastomosis, here is descending. While this, at any part, you get the diameter of the arch plus the descending. So you get significantly wider aorta. Okay? So this technique has much lower rate of recurrence. On the other hand, it is technically a lot more demanding because there's a lot of gap to get, and to be able to get that without tension, because if you get tension, you get recurrence. So if you want to get that without tension, you have to mobilize all the way to the head vessels. You mobilize quite a lot into the descending. You mobilize the collaterals around them and the lymphatics in the area and the nerves. The recurrent laryngeal is very near here. So now you get significantly much bigger operation, but on the other hand, with much better results. So this is cocktectomy and extended end-to-end anastomosis. So most of these techniques, except the one with the extra-anatomical bypass, are actually being done via thoracotomy, and usually a left thoracotomy if the arch is left-sided. So again, this is a view from a thoracotomy. Here's the head and here's the feet. We're looking from the left side, ascending aorta, brachiocephalic, carotid, subclavian, coarctation segment, and descending. And then the clamp, instead of being put here and there to do the end-to-end anastomosis, you actually need to put the clamp just distal to the brachiocephalic and mobilize all the way the head vessels so that this would come and that would come together without tension. And then you extend the incision all the way till just distal to the origin of the carotid. Obviously, you cannot put the clamp more proximal than that because otherwise, this is being done from a thoracotomy without bypass. So if you do that, you obstruct the cardiac output, and actually the body doesn't get any blood. So you have to leave the brachiocephalic period and put the clamp on the descending aorta, and then control any collaterals in between to be able to open this area. But then you get much wider anastomosis, and you end up with something like that. On the other hand, if the narrowing of the narrow part extends all the way to here, this would not correct it because the incision stops there. So this cannot be done with hypoplastic aortic arch, where the hypoplastic segment extends into the proximal arch, just distal to the brachiocephalic. Then you still get residual narrowing if you do just this. Also, some patients will have bovine aortic arch, and what we mean by that is that there is a single branch that gives innominate and left carotid. and then another branch gives the subclavian. So there's no part of the aorta to have the clamp in between the brachiocephalic and carotid. And then you cannot do that, because then if you put the clamp here, you still get a narrow part beyond. So if patients have hyplastic aortic arch with narrowing extending into the proximal arch, proximal to the carotid, or if they have a small arch and essentially they get bovine with the bovine arch configuration, we have to do something more proximal to that. And this is usually done via median astronotomy with an arch repair. And this is a totally different strategy. So now, this is a median astronotomy. We go on cardiopulmonary bypass. And then we need to open the arch. And to be able to open the arch that gives head vessels and descending and all, we usually need to stop the circulation, totally stop the circulation. And to keep the tissues alive, we have to go really hypothermic. So this is total circulatory arrest with hypothermia. And then, so you go on bypass, you start cooling all the way like to 18 degrees or so, and then you just stop the whole circulation, and then you open the arch, and then repair the coarctation segment all the way into the distal ascending aorta. Okay, so that's one option. The other option is that you keep perfusing the brachiocephalic. So you put a cannula from the bypass machine and then into the brachiocephalic, and then you give anti-grade cerebral perfusion. And then you don't need to go that hypothermic. You still are hypothermic, like 24, 26, but then you continue supplying the brachiocephalic, and then you still do the arch repair. Arch repair can be done with the patch or without. So this is one technique with, against sternotomy on bypass, hypothermia. Here they are doing the anti-grade cerebral perfusion and then snaring the head vessels, descending. Once you actually cut the PDA or the ductal ligament, you get quite good access into the descending aorta from the sternotomy. And this technique, the descending aorta is actually anastomosed into the distal ascending, excluding the area of the arch. So these were several surgical techniques. Patients can get balloon angioplasty. Again, we said there's a high recurrence rate, and obviously there is a risk of dissection or rupture or aneurysms. So there's a bit of a leak here. You can see this is the coarctation segment and the balloon taking off the waist, and then the aorta is wider, but then you can get some. On the other hand, patients can get stents, either covered or non-covered, and we've talked about that. So what are different complications for essentially surgical repairs? This is a big operation in a relative, not a big operation, but I mean in a big artery. So essentially without bypass machine most of the time from the thoracotomy. So there is the risk of bleeding. So many of these patients presented with hypertension. Okay, and then so this was the presenting symptoms and was diagnosed with hypertension. And now we're doing the intervention to treat the hypertension. And then they get unexpectedly post-operative hypertension. So you would expect that after relieving the obstruction, the pressure in the ascending aorta will become less. And now the hypertension is resolved. Almost all patients get post-operative paradoxical hypertension. So hypertension not as expected. Why would you develop that? So before correction, baroreceptors around the carotids was used to very high pressure to be able to supply the lower body. So to be able to get a renal perfusion, you have to keep the pressure in the upper body quite high, like 170, 180. And then after the the coarctation repair, the pressure drops from the ascending aorta. And then the baroreceptor will react, causing widespread severe vasoconstriction to get the pressure back into 170, including the lower body, which was used to a pressure of 40, 50. So the lower body gets subjected to really, really higher pressure than before operation. And actually, this is quite dangerous. So the gut, the GIT, gets really high pressure, and then they get mesenteric arthritis, and then widespread occlusions and gangrenes. And then you end up with big gut resection. So it is very, very important to control the paradoxical hypertension early postoperative. It takes a few days in most patients for the baroreceptor to be reset into the new levels of the pressure, and just to appreciate that the actually kidneys are perfused and now we're doing home. So, but on the other hand, during this period, it is very important to treat the paradoxical hypertension, usually with vasodilators, most of the time with sodium nitroprusside, to be able to control pressure. And then patients essentially who get the repair quite late might not get blood pressure to normal. So many of these patients will continue to have antihypertensive drugs. But on the other hand, if this is done in small babies, this usually resolves within a few days. So paradoxical hypertension, mesenteric ischemia, again related to the paradoxical hypertension. And many of these operations require mobilizing lots of the parts of the aorta, similar to the extend end-to-end anastomosis. And then sometimes many lymphatics are being injured. It can be the thoracic duct itself, but most of the time they are just lymphatic channels. This is usually not identified during surgery because the patient is fasting, and then there's not enough flow not enough chyle flow to be seen during surgery. Most of these patients will resolve spontaneously after a period of chest tube drainage, but some will require some interventions. The recurrent laryngeal nerve just passes around the ductal ligament or the PDE, and then this is in the area of the repair, so this can get injured. If a patient gets a recurrent laryngeal nerve MNG, they can get hoarseness, sometimes aspiration. Most of the time, this recovers with time. So let's assume a patient has extended end-to-end anastomosis. Okay. So now we need to control the aorta from here, so that we're able to open into the undersurface of the arch, and then we have to close the carotid, the subclavian, the descending quite low down, so that we can get these together, and any intercostals going into that part because they get collateral flow, and then will not be able to see well, and there will be blood loss. So if the cardiac output, the whole blood coming from the left ventricle will just go into the brachiocephalic, and then along collaterals into the rest of the body. But then, if there's no blood going into the carotid, subclavian, descending, and many of the collaterals, during the part of the clamp, during the period of the clamp, the spine might get ischemic. And then if the spine gets ischemic, you get paraplegia. So when does the paraplegia recover? It does not. And so that's a catastrophic complication for patients with coarctation. It is quite rare, but it does happen. And there are some risk factors for that. So one risk factor is the amount of collaterals that you close, and that's why we should not close collaterals that are not used to control the area of the dissection or the anastomosis. On the other hand, longer clamp time will increase the risk of paraplegia. Okay, when we put the clamp here, if you measure the pressure in the right radial artery, it will be quite high. Sometimes 170, 180, okay, maybe higher. And then if you try to control that blood pressure and lower it down, the amount of blood going through collaterals into the lower body and into the spine will actually be a lot less. And so it is important not to lower the pressure in the ascending aorta during the operation, because this again increases the risk of the paraplegia. One dangerous thing is that if the patient gets high body temperature during this period, because then the metabolic rate will be higher, and the ischemia, the injury that can happen into the spinal cord can occur earlier. And so less mobilization as much as needed, just as much as needed. Lower clamp times, lower body temperature. So we typically do that operation with a body temperature something like 35 or 34 degrees. So bleeding, paradoxical hypertension, mesenteric ischemia, chylothorax, recurrent laryngeal nerve injury, and paraplegia. And so these are actually the early complications. Late complications include recurrence, which we have seen that it occurs with some techniques more than others, and aneurysm formation, again, usually with patch augmentation, patch orthoplasty. So this is a picture of an aneurysm developed following a coarctation repair. So which procedure to choose for which patients? So this is just a suggestion. Usually a patient with a small baby with a localized coarctation is best served with a cocktectomy and extend end-to-end anastomosis. If the patient has hyplastic aortic arch, so the area of hypoplasia extend proximal to the carotid, he's better served with full arch repair from astronotomy and on cardiopulmonary bypass. Patients who are neonates with severe heart failure in a really bad general condition can improve with a balloon angioplasty to be followed later on with surgery. Recurrence after surgery is best served with stent. Adult with the localized coarctation, they can be best served with a stent going into adult size aorta. On the other hand, patients who are adults with difficult arch anatomy can get extra-anatomical bypass. Thank you very much. Any questions?
Thanks, Hatem, for the presentation. During the presentation, I just put some clinical points that might help to put in mind. As Hatem mentioned, in aortic coarctation with interventricular septum, usually we depend on the gradient, either by subcostal view, the dampened flow, or by the gradient that you got across the coarctation. But if you have an coarctation with VSD, don't depend on the gradient, because the flow preferentially will go for the pulmonary, because the pulmonary vascular resistance is usually lower than the systemic vascular resistance. So the gradient will be low because the flow that goes through the aorta is less than the pulmonary. So in coarctation with interposition septum depend on the gradient, but in TGA with BSD depend on the morphology. So in children usually got good images, good quality of images by transthoracic suprasternal view, but if not, keep it low profile to go for cross imaging. That it will help you to get more information.
That's a really important clinical point. So if there's a big VSD, the blood doesn't have to cross across the narrow part, and so most of the blood will go into the pulmonary circulation, and then with the low resistance, and then you do not get any gradient across the arch. So it is important to see that with a 2D imaging, usually with a CT or very good 2D echo.
Yes.
So thank you, sir. Yeah.
Then you go for the morphology that you correlate either with Z-score or the comparison between the ascending and descending, or as Hatem said in neonates that we go for the body surface area plus or minus 2. So we depend on the morphology for that. So if you go for the cross imaging, you have a multi-slice CT or MRI or TE. TE is not an option because this is a blind area. The arch is blind area for the TE. So you choose between the multi-slice CT and the MRI. Usually, multi-slice CT for the structure is better than the MRI. So if you don't have a contraindication, just to go for the multi-slice CT in the preoperative. Multi-slice CT is better, but MRI can help if there is contraindication, like if the creatinine renal function is impaired, MRI will give some idea, acceptable idea, but CT is better for that. Usually it's not needed to be gated if the question is only the coarctation to reduce the radiation. So ask for non-gated CT for safety of the patient, unless you have a question about the intracardiac. So it will be that. For post stenting, CT is your imaging modality because MRI you have an artifact.
A lot of artifacts on the MRI. Yeah.
Having said that, stenting of coarctation is compatible with MRI. So don't be afraid, don't ask for safety measure, for safety questions about that. All the stents of coarctation is compatible with MRI.
Compatible, but they are, you won't get good image for this area of the arch.
If you'd like to evaluate the stent itself, so CT is your imaging modality because it will the MRI will see it like a metal artifact. But if you'd like your patient to go for MRI, like for viability study or evaluation of valve or for
non-cardiac MRI, it is still compatible.
You don't have to worry about that. Just send all the patient. It is compatible with the MRI. Some good points, two good points about that. Not all the patients recovered from hypertension after treatment of the coarctation. So most of them presented as hypertensive patients, and surprisingly, we expected that after relief of coarctation that they should have normal blood pressure, but not all of them, maybe 50% still hypertensive, and we need to put them on medication for that. There is theories about aortic stiffness and insensibility and affection on the renal arteries. It is still theories about that, and a lot of research is going with that. But the bottom line is, don't be surprised if your patient is still hypertensive and you have to put them.
Many adults will not get total recovery of the blood pressure after the operation. Yeah.
For pregnancy, because as Hatem said, in adulthood, discovering that you have a coarctation accidentally is very normal. That most of echoes in adult practice does not focusing on suprasternal view, so actually we discovered. So if you have a pregnant lady, usually we advise against pregnancy in severe coarctation, and we have to, because they will have a low cardiac output manifestations. But if it happens to have a pregnant lady with coarctation, it is a common practice just to go for the cath and do a balloon and stenting for that, putting apron
shield
on the. It is a common practice just to find a lady suffering from coarctation while she's pregnant. It's common practice for the shield from apron and do the catheterization. Usually, the adults, it is an easy job for intervention guys to do coarctation. It is a nightmare to go for surgery because of the collaterals. So it will be blood field, and we would prefer, if it's possible, to go for catheterization more than surgery in adults. It is not. It's the opposite in the pediatric. This was my point.
Really important clinical points. Thank you, sir. Any other questions?
Dilated ascending aorta secondary to aortic coarctation.
Yeah.
How to manage it surgically?
So patients who develop aortic aneurysms and coarctation. This can develop with any patient with coarctation, but actually not rare with bicuspid aortic valves and coarctation. we deal with the distal lesion first, because then if you deal with the proximal lesion and then you still end up with a very high gradient, so you deal with the distal lesion first. If they are both accessible at the same time, you just do both. So if in the very unlikely case that a child present with aneurysm and coarctation, because usually aneurysms develop in adults, but in the unlikely case that a patient has an aortic aneurysm and a coarctation, and he is a child, and you can deal with both in the same operation from a sternotomy, just do both. But then most of the time, this is presents in adults, and actually accessing the descending aorta, going all the way into the descending from a sternotomy in an adult with an aneurysm might be technically difficult. And then it is quite reasonable then to put a stent in the distal part first, so stent the coarctation, and then to be followed with surgery for the aortic, the ascending aneurysm. Obviously, each patient has their own case, and if there are dissections or not, and the extent of the aneurysm and everything. But this is usually the typical scenario.
When you choose the uncovered stent in coarctation operation?
I'm not sure that I'm the one to answer that, but I believe in most cases, using a covered stent, especially in very tight coarctation, especially if the patient is an adult, so you want to dilate that to a quite larger diameter, it is quite safer to use a covered stent. On the other hand, some patients, the coarctation will be very, very narrow to the subclavian artery. And then putting a covered stent will just seal off the origin of the subclavian. And then you need to think, because is it safer to put a covered stent, seal the subclavian, and then depend on collateral flow into that? Or is it good enough to go into the subclavian with an uncovered stent, keep the blood going through the stents there? Our colleagues do all sorts of things, so sometimes they flare the stent into the origin of the subclavian and not totally sealing it off. So, I mean, this is something that needs to be thought about. But as a general rule, I believe putting covered stents are safer. I'm not the best person to answer this question. Any other questions? Thank you very much.
Sure.